recording that. Oh, damn it.
This conference is being recorded. Only the main conference is recorded.
And can I keep that like little on the side? Or is it gonna like get in the way? And I might have to log in onto my computer to let them in. I mean, I'll try to check the chat. Yeah, I'll try to check. I got good morning. Okay. So you should be able to just share screen, and then that's all yours. And then, yeah. So whenever you want to. Yeah. Okay. Try to give it a shot. All right, can everybody hear me? All right, I am Tracy Barker. I am with Medicaid Program Supports and Waiver. I provide Medicaid oversight for the Developmental Disabilities Waivers, and I oversee EPSDT support coordination. So your agencies have contract with me. So not contract, excuse me, that's long gone, performance agreement. So we're gonna go ahead and get started. I think everybody has joined via the Zoom, and if you can't hear us on the Zoom, please let us know. Can everybody see that on the Zoom?
Yes, I see it. Great,
great. Okay, we have sign-in sheets going around, so make sure everybody signs in. If you have a parking pass, I know some of our parking garage is missing one of the little things that goes down. Unfortunately, I can't do anything about that, but if you do have the parking pass, make sure you fill out this top form and then take this to the security office right there, and they will sign it and validate it for you. Do y'all have any questions before we get started? Yeah? Next to the part which is name was first visited on the you can put my name, Tracy Barker. I'm the state employee here. Any other questions? All right. And can I use this one? Can use that one. Should be on.
Okay, can y'all hear me okay? Okay, perfect. And if you're on the Zoom, I'm going to try to keep checking to admit people, and I'll check the chat periodically too if you want to put questions in there. Okay, so my name's Kim Willems, and with SRI, or Statistical Resources, and we are the EPSDT Support Coordination Contractor. The purpose of today's training is to establish a uniform training module for the Support Coordination Agency's designated trainer and supervisors to use in conjunction with the Support Coordination Training Handbook. So this training is going to be used for new support coordinators, supervisors, and trainers hired to serve the EPSDT population as part of the 16 hours of orientation training, as well as for existing EPSDT staff as part of the 20 hours of annual training, and as reference material for support coordinators and supervisors. So I emailed out attachments of all of the training materials. So if you didn't get that, just let me know. It came in 3 different parts, but you can also always visit the EPSDT support coordination website on LDH. It's much easier to print the materials from there. But if you ever need a Word document or an Excel file or something, just let me know and I can send that. Okay, so the training's broken up into 3 parts. Part 1, we're going to go over services available to EPSDT beneficiaries. Then we're going to discuss intake, assessment, and plans of care. Then we're going to talk about coordination of services and PA tracking, and then other support coordination requirements. Part 2 is information specific to Medicaid managed care. And then part 3, we're going to go over the COVID-19 exceptions. And then in the back of the room, I had 2 handouts for y'all. This was also attached to the first email that I sent. So we're just going to talk about those at the end too. Okay, so EPSDT stands for Early Periodic Screening, Diagnostic, and Treatment. This program was established as a result of a lawsuit, Chisholm versus LDH, to provide support coordination to those individuals who have disabilities and/or chronic health conditions. So to be eligible, it's individuals on the Developmental Disabilities Request for Services Registry or individuals for whom the service is determined medically necessary with documentation to substantiate that they meet the definition of special needs. And you can find the full definition on Appendix P. You also have to be under the age of 21 and Medicaid eligible. So if you hear us talk about Chisholm class members, that just means children under the age of 21 who currently receive or are eligible for Medicaid and who are on the Developmental Disabilities Request for Services Registry. Okay, so there's Legacy Medicaid and Medicaid Managed Care Program. Legacy Medicaid, or fee-for-service, is traditional Medicaid for people who are not enrolled in a managed care organization for most of their health services. Chisholm class
We are
members,
not seeing the PowerPoint if you're
okay.
sharing.
Share screen options. Okay, can y'all see it now on the Zoom?
Yes.
Okay, perfect. Okay, and then the Medicaid Managed Care Program is Healthy Louisiana is the way most of Louisianians' Medicaid beneficiaries receive health care services. The state contracts with managed care organizations, or MCOs, that deliver these services through their provider networks. Some of these MCOs have a different network of doctors, hospitals, and other providers than traditional Medicaid. Some Medicaid beneficiaries only receive specialized behavioral health services and transportation through their health plan. Chisholm class members may choose to have their health care through the health plan or only their specialized behavioral health services. This is called opt-in. And then CSOC, which is the Coordinated System of Care, waiver recipients will access most of their specialized behavioral health services and CSOC through Magellan. No, it has just been popping up, by the way.
Just bear with us, guys. We have some people in the waiting room that we need to allow in. Come on. Okay. Let me make it. We did this one?
Wow.
Okay, can y'all see it on the screen now? Everybody can still see?
Yes, we can.
Okay, sorry about that, guys. Okay, so now we're going to talk about services available to EPSDT beneficiaries. Children and youth receiving EPSDT support coordination are eligible to receive all medically necessary Medicaid services that are available to people under the age of 21. In addition, if they are placed on the Request for Services Registry, they may be eligible for services through the Louisiana Developmental Disabilities Services System, administered by the Office for Citizens with Developmental Disabilities through the local governing entities. Services through the Office of Behavioral Health are available for children and youth with emotional disturbances. Children and youth may be able to receive services through the school system or through early childhood education programs. Through Medicaid, children under the age of 21 are entitled to receive all medically necessary healthcare, diagnostic services, and treatment, and other measures coverable by Medicaid to correct or improve physical or mental conditions, even if these are not normally covered by Medicaid for beneficiaries aged 21 or older. Persons under age 21 are entitled to receive all equipment that is medically necessary. This includes many items that are not covered for adults, and these services may be subject to any restrictions allowable under federal Medicaid law. And you can refer to Appendix F for an expanded list of services available to Medicaid-eligible children under the age of 21. So some of the Medicaid services that are available include EPSDT support coordination, psychological evaluations, medical, dental, vision, and hearing screenings, both periodic and interperiodic, speech and language evaluations and therapy, occupational therapy, physical therapy, personal care services, extended home health, pediatric day health care, dental care, hearing aids, eyeglasses, medical equipment and supplies, applied behavioral analysis, and any other medically necessary healthcare, diagnostic services, treatment, and other measures which are covered by Medicaid, which includes a wide range of services not covered for recipients over the age of 21. There are no fixed limits on the amounts of services beneficiaries under age 21 can receive. They are entitled to as many doctor visits and as many hours and amounts of any other services as are medically necessary for their individual conditions. Medicaid offered services are more comprehensive than services offered through schools as part of a child's IEP. IEPs only cover services that help with a child's education. Medicaid, outside of the IEP process, covers services needed to help any other aspect of a child's life as well. And some Medicaid services must be prior authorized before the service can be provided. And the updated Medicaid services chart can always be found on the LDH website. Even if a service is not on the Medicaid services chart, it must still be covered if it is a service permitted by federal Medicaid law and is necessary to correct or ameliorate a physical or mental condition of a beneficiary who is under age 21. And the handbook is going to provide more detailed information about specific services. So EPSDT support coordination, parents of children with developmental disabilities are sometimes unaware of the services that may be available to assist them. Therefore, it is important for the support coordinator to be knowledgeable of these services and how to access them. As a support coordinator, it is your responsibility to make suggestions for these services. Do not wait for the family to request a service. If you see a need for one of these, inform the family and document their response. If the child may need additional services, but it is not clear, suggest appropriate evaluations to determine whether there is a need. If the family states they aren't interested in the service, accept that. However, feel free to remind the parent of the service again when the opportunity presents. So the support coordinator is going to develop a full list of all services a beneficiary needs and then help them get and coordinate these necessary services. Parents often do not understand aspects of the Medicaid system. Therefore, one of the primary responsibilities is to follow through with requests for services until the prior authorization is either approved or denied based on medical necessity. And when approved, make sure the services are provided as authorized. Okay, so now we're going to talk about some of the individual Medicaid services. Applied behavioral analysis uses behavioral observation and reinforcement to teach skills, increase useful behavior, including communication, and reduce harmful behavior. It's based on reliable evidence of their success in alleviating autism and other related disorders and is not experimental. For Medicaid to cover ABA through a licensed provider, the person must be under the age of 21, exhibit the presence of excesses and or deficits of behaviors that significantly interfere with home or community activities, things like aggression, self-injury, or elopement. They have to be diagnosed by a qualified healthcare professional with the condition for which ABA-based therapy is recognized as therapeutically appropriate, including autism spectrum disorder. And they'll have a comprehensive diagnostic evaluation by a qualified healthcare professional and have a prescription for ABA-based therapy services ordered by a health professional. So usually the CDE will have the prescription in there, so you wouldn't need that separately. To find an ABA provider in your area, you can call the managed care organization of the beneficiary, and all those contact numbers are on Medicaid Managed Care Appendix B. If a beneficiary wants to see if they qualify for ABA, you can contact the beneficiary's MCO and complete a referral for a clinical diagnostic evaluation. And for more information, you can contact the MCO or LDH directly, and you can refer to page 11 of the handbook. Transportation services, we have non-emergency medical transportation or NEMT, and that's provided for Medicaid beneficiaries to and or from a provider for a Medicaid covered service. All beneficiaries can access this service through their MCO, and the transportation phone numbers are also found on Medicaid Managed Care Appendix B. Children under 17 must be accompanied by an attendant, and arrangements should be made at least 48 hours in advance. Transportation must be provided in all parishes and to all eligible beneficiaries. If there is a need for special arrangements, such as lift-equipped transportation, the MCO must ensure that such arrangements are made promptly so that the beneficiary can obtain the medical services they need. The role of the support coordinator is to assist the beneficiary in arranging transportation. And then there's also the gas reimbursement program, it used to be called Family and Friends. So it's basically where the family member or friend can become a Medicaid-funded transportation provider for specific family members through the gas reimbursement program. The program pays the beneficiary's friend or family member to take them to medical appointments when certain conditions are met. And then a couple things to keep in mind, the provider may not reside at the same address as beneficiaries that they transport, and this includes parents of children in the same household. Beneficiaries cannot be reimbursed for transporting themselves to appointments, and to assist someone you're serving that may benefit from this arrangement, you can contact the beneficiary's MCO. And now we're going to talk about behavioral health. So the first one is Coordinated System of Care, or CSOC. CSOC was developed for Louisiana's children and youth with significant behavioral health challenges or co-occurring disorders that are in or at imminent risk of out-of-home placement. CSOC offers an array of Medicaid state plan and home and community-based waiver services to children and youth in need of mental health and or substance use treatment who are deemed clinically and financially eligible. CSOC is an evidence-informed approach that enables children to successfully live at home, stay in school, and reduce involvement in the child welfare and juvenile justice systems. So CSOC might be right if the child is 5 to 20 years old, has a mental health or co-occurring disorder, has a history with child welfare, juvenile justice, or trouble in school, and is an out-of-home placement or at risk for being placed out of the home. So things like developmental disabilities facilities, psychiatric hospitalizations, foster care, things like that. Partners play a very important role in the success of CSOC. CSOC intends to ensure that efforts on behalf of children and families are integrated across systems. CSOC is a family-driven process, therefore referrals should be made with the parents, guardians' knowledge, consent, and participation. So to make a referral, you can call Magellan directly at the 1-800 number, or you can call the beneficiary's MCO with the parent or guardian present or on the phone. The MCO will ask initial risk questions and transfer the call to Magellan if the child meets criteria. And then Magellan will conduct a brief child and adolescent needs assessment to establish preliminary eligibility. If based on the CANS assessment they're eligible, Magellan will refer the child or youth to a wraparound agency to ensure that a comprehensive assessment is completed, offer the child, youth, and the family an opportunity to participate and begin forming a child and family team. Regardless of CSOC eligibility, their MCO will ensure that the child or youth is referred to providers who can meet their needs. So when they're enrolled, they'll be assigned a wraparound facilitator. The child and family will work with the facilitator to develop a plan of care with a team of people. The plan can include services and supports to meet their behavioral health needs, as well as other needed services and supports that affect their well-being. So some of the CSOC services include parent support and training, youth support and training, short-term respite care, and independent living and skills building. If a beneficiary is part of CSOC, they can access specialized behavioral health services by contacting Magellan at the 1-800 number. And then mental health and substance use disorder services include psychiatrist visits, psychological and or behavioral services from a licensed psychologist, counseling, substance use disorder treatment services, and then mental health rehabilitation, community psychiatric support and treatment, which includes multi-systemic therapy, functional family therapy, home builders, and assertive community treatment, and then psychosocial rehab. So all those ones with the asterisk next to them require a prior authorization from the MCO. And the provider will arrange for the assessments necessary to obtain the prior authorization for rehabilitation services. But if they're in CSOC, they'll access those through Magellan, and services through Magellan do not require PA tracking by the support coordinator, and you would leave the behavioral MCO agency blank and ALSIS. And then also under mental health rehab is crisis intervention and crisis stabilization. Oh. Just a second, all the screen went off. Yeah.
I think here you said that the CSOC, it doesn't require transmission from the SC, that it's something like else.
Okay, so there was a question about CSOC. So if you're a CSOC waiver recipient, then most of your behavioral health services are going to be accessed through Magellan, which as an EPSDT support coordinator, we don't have to do the PA tracking for. So when you pull the electronic Medicaid eligibility verification, it should have on there something about coordinated system of care, and then we would just leave the behavioral MCO agency blank and ALSIS. And then I emailed a little guide of how to read the Medicaid eligibility verifications. If you didn't get a copy of that, just let me know. But basically when you pull it, there's gonna be one section that says, I think, physical medicine, and then if they have an MCO, it'll list it, and then there's gonna be one that'll say specialized behavioral health, and we'll list their health plan. And then if you don't see the physical health one, then they're with legacy Medicaid, and you would just leave that drop-down box blank.
It went on and then it went right back on.
Could you clarify something? So it looks like from the slide that every child that is approved by the OTDD becomes a CHISM member. Is that right?
Yes. So to be a CHISM class member, you have to be on the Developmental Disabilities Request for Services Registry.
Right.
So if you're coming out of early steps, you'll become a CHISM class member when you're officially placed on the registry and you get your statement of approval from the LGE.
But if they apply for a waiver, I read that then the CHISM designation stops.
So once you receive a waiver offer, then you're no longer on the registry and you would no longer be a CHISM class member.
Oh, you actually come up.
Yeah. So once you receive the offer. So we have a couple kids that are labeled as non-CHISM and ALSIS, and then it should tell you, like we auto-populate that at SRI, so it should tell you like the reason why that they've received a waiver offer. Or that they were found ineligible for services. So if they're special needs, then they would be non-CHISM, because you're not on the registry anymore.
Okay. So special needs are not on the
So
register.
special needs is if you get a statement of, or a lot of the kids, is if you get a statement of denial from the LGE, then we can look to see if they meet the definition of special needs. And then they could continue to receive EPSDT support coordination because they're Medicaid eligible, they're under 21, and they meet the definition of special needs.
So how do they access that?
You'll contact me, and then I'll forward it to Tracy Barker, and she'll complete the review, and then we'll send you a letter saying that they qualify or not, and then I'll label them as special needs and ELSIS.
Okay, I don't know what's happening.
Does everybody have a printout of the PowerPoint?
Y'all have a printout?
Okay. And they can see it on the Zoom.
Yeah, y'all can,
So-
I don't know why it went off. I got here early and it worked fine. Of course it has to work. It's not working anymore.
Okay, so we're on slide 33. If everybody has the printout of it, that's in person, and we'll see if we can get it working. Okay, so behavioral health, there's licensed practitioner outpatient therapies, which includes parent-child interaction therapy, child-parent psychotherapy, PTSD treatment, triple P positive parenting program, trauma-focused cognitive behavioral therapy, and eye movement desensitization and processing therapy. And there's a really good referral guide on laevidencetopractice.com. So if you go to that website, they have a couple different referrals. They have one that kind of shows you what ages each service is for and what it works on and that kind of stuff. So definitely take a look at that. And you can also refer to handbook page 16. And then we have residential and hospital-based behavioral health treatments, including therapeutic group homes, psychiatric residential treatment facility, and inpatient hospitalization. And then school-based behavioral health services, Medicaid will also fund behavioral health services provided through schools or early childhood educational settings for children ages 3 to 21, such as regular kindergarten classes, public or private preschools, child care facilities, et cetera. To be funded by Medicaid, these services must be included in the child's IEP, and behavioral health services, treatment, and other measures to correct or ameliorate an identified mental health or substance use disorder diagnosis may be provided by licensed mental health practitioners or Louisiana certified school psychologists and counselors. All right, and now we're going to talk about physical health services, including EPSDT screening exams and checkups. So Medicaid beneficiaries under the age of 21 are eligible for well-child checkups or EPSDT screenings. So the checkup is going to include a health history, physical exam, immunizations, lab tests, vision and hearing checks, developmental screening, autism screening, perinatal depression, and dental screening. Checkups are available both on a regular basis and whenever additional health treatment or additional services are needed. There are no limits on the number of visits that are medically necessary for the beneficiary's condition. In addition, an interperiodic screen can be obtained whenever one is requested by the parent or is recommended by a health, developmental, or educational professional, including a support coordinator, in order to determine a child's need for health treatment or additional services. When detected early, medical conditions such as lead poisoning, sickle cell anemia, developmental delays, nutritional deficiencies, and behavioral disorders consistently result in successful outcomes and cost-effective treatment plans. Primary care physicians are responsible for making appropriate referrals when needed based on the results of a screening. And then EPSDT personal care services, PCS, is provided by direct service workers and defined as tasks that are medically necessary as they pertain to an EPSDT beneficiary's physical requirements when cognitive or physical limitations due to illness or injury necessitate assistance with eating, toileting, bathing, bed mobility, transferring, dressing, locomotion, personal hygiene, and bladder or bowel requirements. Assistance is provided with meal preparation if the beneficiary is on a restricted diet that differs from the rest of the household and no family member is preparing the meals. PCS does not include medical tasks such as medication administration, trach, feeding tube, or catheter requirements. Assistance with these tasks can be covered through Medicaid's home health program, and you can refer to Appendix E for the full PCS rule information and for a comparison of PCS and home health. PCS is not intended as a substitute for childcare needs or to provide respite care to the primary caregiver. A parent or adult caregiver is not required to be in the home while services are being provided to children. So PCS is authorized through Gainwell Technologies if the participant has legacy Medicaid for physical health or the MCO, if they have an MCO for physical health. The provider must complete a social assessment form, a daily time schedule, and develop a plan of care. A practitioner must complete an EPSDT PCS Form 90. And I know some of the providers have been giving the parents 90Ls, so make sure that they have the Form 90, which is going to be the 3-page form. So the practitioner can fill that out, which will prescribe or refer the service and sign the provider's plan of care. The number of hours approved is based on assistance with the personal care needs that are covered through this program. There are no set limits to the number of hours a beneficiary can receive. The support coordinator should assure that the practitioner has all critical information before the services are prescribed, and all PA requests should include necessary documentation to support the medical necessity of the request. What is extended skilled nursing services, also known as extended home health? Extended skilled nursing is nursing care provided to beneficiaries under the age of 21 who are considered medically fragile. Extended skilled nursing must be prior authorized unless the visit is less than 3 hours per day. A prescription is needed from the doctor stating the number of hours requested and a letter of medical necessity justifying the reason for extended skilled nursing services. Home health services for children and youth are not limited in terms of frequency or duration, but are based on medical necessity. And then skilled nursing, intermittent or part-time, is if it's for less than 3 hours a day, and that can be prescribed by a doctor and obtained without prior authorization for beneficiaries aged 0 through 20. These services must still be ordered and provided by a home health services provider. And then also under home health are home health aid services and rehab services, which is physical, occupational, and speech therapy that can be provided in the home, an outpatient facility, an early intervention center, a rehab center, or at school. And all rehab services must be prior authorized. And then we have pediatric day health care, which serves medically fragile individuals under the age of 21, including technology-dependent children who require close supervision. PDHC facilities offer an alternative healthcare choice or supplement to receiving in-home nursing care. PDHC may be provided up to 7 days per week and up to 12 hours per day is documented by the beneficiary's plan of care. Care and services to be provided shall include, but shall not be limited to, nursing care, which includes trach and suctioning, medication management, IV therapy, and gastrostomy care, respiratory care, physical, speech, and occupational therapy, assistance with activities of daily living, and then transportation to and from the PDHC facility. And then we have physical therapy, occupational therapy, speech therapy, and audiology services. So for Medicaid to cover these services at school, it has to be part of the child's IEP or individualized family support plan. For Medicaid to cover these services through an outpatient facility in a rehab center or home health, they must be ordered by a physician and must be prior authorized by Medicaid. The support coordinator is to explain to the beneficiary family that Medicaid will provide medically necessary therapies in addition to the therapies received at school through the IEP. And then I always recommend that you'll go over the IEP with the parents and make sure they're aware of how much therapy they're actually receiving at school too. The support coordinator is to ask the beneficiary if they want to request any medically necessary therapies now, or if they want to receive therapies on the IEP during the school summer break. The support coordinator helps the family to determine the setting in which the child will receive the greatest benefit, and also helps the family by making the appropriate referral and coordinating the days and times of this service with other services the beneficiary is receiving and monitoring the delivery of services. Medical equipment and supplies. Beneficiaries are entitled to any medically necessary medical supplies, equipment, and appliances needed to correct, improve, or assist in dealing with physical or mental conditions. This includes lifts and other devices to help the family deal with the child's circumstances, such as communication devices, and also some medically necessary dietary or nutritional assistance. Medical equipment and supplies must be prescribed by a physician and prior authorized. Disposable incontinence supplies for children aged 4 through 20, and it's based on medical necessity. Diapers, pull-on briefs, and liners or guards may be covered. So you should start PA tracking for diapers 60 days before the child's 4th birthday, and you'll just instruct the provider to use the birthday as the PA request date. And you can refer to Appendix R1 for more information and the prescription request form for disposable incontinence supplies. And R1 also has the Form 90 and some other prescription forms. Medicaid or MCO prior authorization unit may approve less expensive items that it believes will meet a beneficiary's needs. If so, the notice of denial should identify the item. The beneficiary can accept the less costly item and still appeal the denial of the item originally requested. However, they must not dispose of, destroy, or damage beyond normal wear and tear the less expensive item while the appeal is pending. You should consult with the beneficiary and the provider to see if the less costly item identified will work and help the beneficiary decide whether to appeal for the item originally requested. The support coordinator must explain appeal rights to the family and assist in the appeal if the beneficiary wants that help. And then you could, again, refer to Appendix F for an expanded list of available services. To ask about available services, you can contact the Specialty Care Resource Line or the beneficiary's MCO member services line or the Medicaid Managed Care Case Manager. Although a service may not be listed, if it is a service permitted by federal Medicaid law and is necessary to correct or ameliorate a physical or mental condition of a recipient who is under age 21, it must be covered. Persons under age 21 are entitled to receive all equipment that is medically necessary, and this includes many items that are not covered for adults. These services may be subject to the restrictions allowable under federal Medicaid law. Now we're going to talk about some of the non-Medicaid services that are available. So some of the services through OCDD local governing entities include flexible family funds, individual and family support, local governing entities support coordination, and you can refer to page 25 of the handbook, and then Appendix G has all the contact information for you. Services through Office of Behavioral Health. We have Community Behavioral Health Services, Child Adolescent Response Team, and that contact information is found on Appendix I. Services available through school systems. Each school system in Louisiana has a child search coordinator who can arrange for evaluations of children to determine whether or not the child has a disability and requires special education services. And you can refer to handbook pages 28 through 30 and also other community services. And then our home and community-based waivers for people with developmental disabilities. Most children currently receiving EPSDT support coordination are on the Developmental Disabilities Request for Services Registry. So there's the New Opportunities Waiver, which provides comprehensive home and community-based services for individuals 3 years of age or older. The Children's Choice Waiver, which provides a limited package of services to children under the age of 21. The Supports Waiver, which provides specific services, activity-focused services for those age 18 or older. And then the Residential Options Waiver, which offers expanded home and community-based services for individuals of all ages. And then we have updated fact sheets for all of those in Appendix D. And then some facts about Children's Choice. Children's Choice waiver opportunities shall be offered to individuals under the age of 21 who are on the registry, have the highest level of need, and the earliest registry date as slots become available. Services are capped at $20,200 per care plan year and can be used for medical care, home and vehicle modifications, caregiving assistance and support, and other specialty services. When the family chooses to accept Children's Choice, the child's name is taken off of the Developmental Disabilities Request for Services Registry. Youth who reach the age of 18 and want to work may choose to transition to a supports waiver as long as they remain eligible for waiver services. Youth who continue in the Children's Choice Waiver beyond age 18 will age out when they reach their 21st birthday. They will transition to the most appropriate waiver that meets their needs as long as they remain eligible for waiver. Okay, and then what happens at age 21? The beneficiary becomes ineligible for some services, including support coordination, EPSDT personal care services, extended home health, incontinence supplies, and other items or services that are not part of Medicaid services for adults. So your role is to inform the beneficiary of the change in Medicaid services and encourage them to obtain exams, dental care, glasses, durable medical equipment, et cetera, prior to aging out. The support coordinator should be aware of available services and make arrangements to transition the beneficiary to receive all services he or she may need in order to continue to live in the most integrated setting that is appropriate for him or her. The support coordinator should begin making arrangements for transition at least 6 months prior to the beneficiary's 21st birthday. And LSIS will prompt you to add transition as a service need, and we'll set a transition strategy in the additional information section. And provider agencies may need to be changed if the current provider only services children. So some of the available services may include OCDD, including extended family living, supported independent living, and vocational and rehab services, long-term personal care through Medicaid. So beneficiaries who receive EPSDT PCS will be contacted by Conduit regarding LTPCS. The support coordinator should inform the family to expect notification over the phone or mail, and you can also call the 1-877 number for additional information. Louisiana Rehabilitation Service, or LRS, may provide assistance with services needed to pursue short or long-term employment goals, including higher education, and you can call the 1-800 number for additional information. And then Office of Aging and Adult Services, the Community Choices Waiver, and Adult Day Healthcare Waiver, and that's only if they have a statement of denial from OCDD, such as those receiving special needs support coordination. And you can call the 1-877 number to request to be placed on the OAAS Request for Services Registry. Okay, so any questions about Medicaid or non-Medicaid services? Okay, so we're going to talk about intake, assessment, and plans of care. So how to access EPSDT support coordination. So again, it's available to all Medicaid beneficiaries under the age of 21 who are on the DD Request for Services Registry or for whom the service is determined medically necessary, with documentation from Medicaid to substantiate that the EPSDT beneficiary meets the definition of special needs. Beneficiaries may elect to receive or discontinue EPSDT support coordination at any time. Discontinuing EPSDT support coordination does not affect a beneficiary's eligibility to receive Medicaid services or their placement on the DD Request for Services Registry. Beneficiaries may request to resume EPSDT support coordination services at any time by calling SRI toll-free at 1-800-364-7828 and requesting support coordination for EPSDT. And Ms. Pat Carter is the one at our office that handles all of those requests. If an individual is not on the DD Request for Services Registry, they can contact their local governing entity, and those contacts are on Appendix G. If they receive a statement of denial from OCDD, they may still be eligible for EPSDT support coordination if they meet the definition of special needs. So just contact me if you ever get a statement of denial. You can go through the appeal process, and then we can submit documentation to Tracy Barker to see if they meet the definition of special needs. Okay, intake. So you get a linkage from SRI, and then you're going to contact the beneficiary and or legal guardian within 3 business days of the referral to the support coordination agency. At that time, a face-to-face in-home appointment should be set up within 10 calendar days. to discuss what support coordination is and how it can benefit the individual. The individual should be asked about formal information documents they may have or can obtain prior to the CPOC assessment, including the current IEP, and then if they're receiving PDHC or extended home health, we're required to have that current plan of care on file. So go ahead and request all of that at your first phone call. The support coordination choice and release of information form, which is the linkage or the freedom of choice, must be used to obtain all plans, evaluations, assessments, and documents that OCDD has developed or used in connection with its determination that the beneficiary is eligible for services through the Developmental Disability Services System, including the statement of approval. So if you're just getting the statement of approval from the LGE, you can also request any documents that they use to make their determination. So if it was done recently, you may get lucky and be able to get a copy of the IEP or another document that we can use as our formal document. And you'll allow OCDD a 5-workday turnaround. And if you are having any issues, just forward me the email and I can follow up. And then there's also a participant recap sheet, I think they call it. So if the SOA is ever misplaced, they should be able to print out their OCDD participant services sheet for you, which will have all the SOA dates on there. And you can refer to Appendix N for a sample of the consent form. Okay, and then we talked a little bit about this, but Medicaid eligibility verification, the support coordinator will use MEVRES or EMEVs to determine if the beneficiary is eligible and remains eligible for Medicaid. The support coordinator will check for continued eligibility monthly, and if the beneficiary becomes ineligible for Medicaid, they are no longer eligible for support coordination, and closure procedures shall be followed as identified in the handbook, page 113. And then if they're closed for less than 6 months and they contact you and their Medicaid was reinstated, you can open them back up in ELSIS, but just let me know if you do it so I can get the PA reissued. If it takes them longer than 6 months to get Medicaid back, then we would have to treat it as an initial, and you would direct them to SRI to get a new linkage. So you can close them for less than 6 months, but if it's more than 6 months, you can't reopen them on your end. We have to do it as an initial. Okay, at the face-to-face visit, so that's going to be conducted within 10 calendar days of the referral to your agency. You're going to determine if the individual accepts support coordination and agrees with the contact requirements, including the required face-to-face meetings. The individual is often overwhelmed with everything they're being told in this first meeting. Do not expect the individual to remember everything, even if you're providing information in writing. Review this information as often as is necessary. And this is a list of all of the documents to go over with the family at your first face-to-face meeting. So the Medicaid services chart, which is Appendix C, services available to Medicaid eligible children under age 21, Appendix F, support coordination, rights and responsibilities, Appendix K, the appeal process, Appendix L, the complaint process for filing a report against support coordinators and or legacy Medicaid providers, Appendix M. And then if it's a Chisholm class member, make sure you discuss their right to choose between legacy Medicaid and the Medicaid managed care program for their physical health services, and that's all explained in Medicaid managed care, Appendix H. The complaint process for filing a report against MCOs or Medicaid managed care program providers, which is Medicaid managed care, Appendix I. And then all of your support coordination agency policies, including HIPAA and confidentiality, referral to EPSDT screening provider if it's requested, and then the availability of formal and non-formal services. So assessment must begin within 7 calendar days of linkage and prior to the CPOC meeting. Assessment is the process of gathering and integrating formal and informal information relevant to the development of a CPOC. Formal information includes medical, psychological, pharmaceutical, social, educational information, and information from OCDD. Informal information includes information gathered in discussions with the family and beneficiary, and may also include information gathered from talking to friends and extended family. The SC is to obtain all assessments, evaluations, and documents that OCDD use to determine eligibility, the current IEP if they're receiving special ed, the current home health plan of care, or the current pediatric day health care plan of care if they're receiving those services, and any other assessments by professionals like the EPSDT Form 90, LRS and special education evaluations, behavior plans, psychological and other evaluations that are required to obtain CPOC approval. The SC is to contact OCDD, schools, pupil appraisal, and healthcare providers for necessary records. Ask the individual about documents they may have or can obtain from their school, and follow up on requests for records. The support coordinator may need to assist the beneficiary with arranging professional evaluations and appointments, including well child visits, EPSDT screening exams, and follow-up evaluations. The information provided as a result of these appointments could prove critical in the assessment that will be used to develop the beneficiary's person-centered comprehensive plan of care. The CPOC is the support coordinator's blueprint for assisting the individual. It's developed through a person-centered planning process and is based on the comprehensive information gathered during the assessment process, which identifies the individual's preferences, needs, goals, abilities, health status, and available support. The CPOC must be completed in a face-to-face in-home meeting with the individual's support team. The individual and the legal guardian must be present. The support team is made up of the individual, legal guardian, support coordinator, and other people chosen by the individual that know them best, such as family, friends, or other support systems, or direct service providers. All references to the individual include the role of the individual's representative. And everyone present at the meeting must sign the CPOC participant signature page in the planning participants box. So also at intake, you're going to determine if the beneficiary is a competent major, which is someone that's 18 years of age or older and has not been legally declared incompetent. So if they are a competent major and they're able to express their preferences, like in the demographic section of LSIS, you're going to label them as a competent major, and then it's going to have a question box pop up if they're able to direct their own care or not. So if you put a yes there, then you have to talk directly to the competent major and have them sign all documents. But they can also choose to have an authorized representative by completing the authorized representative form appendix U. If the competent major is unable to express their preferences due to a disability for which an accommodation cannot bridge the gap, the support coordinator should document why they believe the competent major is not able to direct their own care and must obtain an authorized representative form or a supported decision-making agreement. And you can refer to pages 33 to 34 of the handbook, or just give me a call with any questions specific to your participants. The CPOC is based on the identified needs and the unique personal outcomes envisioned, defined, and prioritized by the individual. The CPOC must include agreed upon strategies to achieve or maintain the personal outcomes using appropriate natural community supports, non-formal and formal paid services. The CPOC must include timelines in which the personal outcomes can be met or at least reviewed. The minimum requirement is quarterly, and the support coordinator is responsible for providing complete and clear information to assure the individual can make informed choices regarding the supports and services they receive and from whom. During the CPOC meeting, the support coordinator must use the Medicaid services chart to discuss available Medicaid services. Do not wait for the individual to request a service. If you see a need for a service, inform the individual and document their response. So I'm always looking for this when reviewing plans of care. So if I see a need for something, I'm going to ask you if that service was offered. So if you're saying that they need assistance with their activities of daily living, I'm going to look for a specific sentence saying that you offered PCS and then what the family's response was. Either they requested it or they declined it. Or if you say that they have a speech delay, did you offer speech therapy? And did the family request it or decline it? Just so it's very clear that it was addressed. If the individual may need additional services, but it is not clear, suggest appropriate evaluations to determine whether there is a need. One of the primary responsibilities of the support coordinator is to follow through with the request for services. The CPOC is to be completed electronically in LSIS, which is the Louisiana Support Coordinator Information System. The SC should review a blank copy of the plan of care and instructions before conducting each CPOC. The CPOC is designed to briefly summarize important information so that it can be reviewed and considered in evaluating the need for proposed services and supports. Information relevant and applicable to justifying services requested by the individual must be provided. So like if you're saying that they're requesting PCS, I would be looking for a statement about what activities of daily living they're going to assist with. Or if you're requesting behavioral services, then you should be addressing behavior. The CPOC should always emphasize the individual's personal outcomes. The goal is to provide support and services in a person-focused, cost-effective, and accountable manner. Okay, and then the 6 sections of the CPOC. Section 1 is demographic information. Section 2, medical, social, family history. Section 3, service needs. Section 4, CPOC participants. Section 5, CPOC approval. And the typical weekly schedule, which is still a paper form, is going to be Section 6. So the initial portion of the plan of care is self-explanatory. It requires the SC to develop current contact information on the individual, including name, mailing, and physical address, good contact numbers, social security number, Medicaid ID, ICD-10, et cetera. Nothing should be left blank. And if you ever need us to update your support coordination prior authorization, just send me a copy of the Medicaid eligibility, because we always want to match what Medicaid has. So if you get a linkage and it's not the correct information, just send me a copy of what Medicaid has on file and we can get that updated. And then there's a little box for legal guardians, so make sure that you are documenting their full name and then also their relationship to your participant. If the individual is a competent major, then you'll be prompted to document if they can direct their own care. And then slide 78 is a screenshot from LSIS of what the demographics looks like. Is there any demographic questions? Okay, and then section 2 is medical, social, family history. So this provides information about the past and current situations in the beneficiary's life and about their family. Interview those who know the beneficiary best. Natural supports should be explored to determine who is involved in the beneficiary's social support network. Information included on this section is relevant to the beneficiary's life today and provides a means of sharing social family history. If any information is unknown, you can always document that it's unknown, and then I'll know that that was addressed. If there's only sketchy information available in any health status area, remember that the beneficiary is eligible for screenings, which can help to determine his or her health needs. It is the support coordinator's responsibility to help the beneficiary access those screening services. In addition, it's important to remember that psychological and behavioral services are available for the beneficiary and should be offered. Always document the offer of services and the response received. And then so it's like tab 2 in LSIS, there's going to be 4 different boxes that you fill out. So the past is going to address prenatal health and birth, the nature and cause of the disability if it's known, the age of diagnosis and who made it, any early intervention services received, any placement history outside of their current placement, any past medical history, surgeries, or hospitalization. So if it happened more than a year ago, but it's significant, you can keep it in the past section. And then events that led to the request for services at this time. And if there are no services to coordinate, make sure you document that the family is aware that support coordination is optional and that declining will not affect their eligibility to receive Medicaid services or their placement on the DD Request for Services registry. And then the present section, you're going to describe the current living situation and their natural supports. So you'll provide the names and ages of all household members, and then address their family situation and social support network. And if their parents don't live in the home, make sure that you address both mom and dad, and if they provide any natural or financial support. Relevant social, environmental, and health factors that impact the beneficiary. If they have access to community or the transportation, source of household income, desires and requests, and their education needs. So again, all this stuff is just looking at what services we can refer them to. So if they don't have access to the community, did we offer non-emergency medical transportation? Is there a need for the Family Flexible Fund through the LGE? And then the medical diagnoses section is going to be a brief narrative description of the person's health history, current medical condition, including medical diagnoses, hospitalizations, and continuing health concerns, and medical needs should be included. So the first thing is to list all their diagnoses and what current formal documentation you have to support their qualifying diagnosis or diagnoses. So generally, it's just going to be the 2022 IEP documents, developmental delay, or whatever that primary exceptionality is on the IEP. And then if you're using another formal document, like an extended home health plan of care or Form 90 or whatever it is, you'll just write a sentence about what your formal document is and what diagnosis it documents. If any diagnosis is parent state and you don't have documentation to back it up, address what you're doing to obtain the documentation. And if no documentation exists, address if they want a referral for an evaluation. List all medical specialists, so you can just put like Dr. Smith, neurologist, seeing PRN, and then document their last visit if that's known, and their next visit if that's known. And you don't have to give me like the exact date, but just so I'm really just trying to determine if they're overdue for any doctor visits so that we can add that as a service need. And then we also always want to address dental care. So if they haven't been to a dentist, make sure you're documenting if that's declined or when the last time they went, and you can always offer scheduling assistance. You can schedule non-emergency medical transportation. So if there's ever any issues, make sure you're covering your bases with that. And then list all medications and what they're prescribed for. And then we're going to talk about the client. So discuss their vision and hearing. If that's within normal limits, if they need a referral for at their EPSDT screening, they'll do vision and hearing screenings. But if they need to see an eye doctor or an audiologist, hearing aids, eyeglasses, things like that. How they communicate, and if they're nonverbal, try to give me nonverbal ways that they communicate. Or if they're verbal, do they speak in full sentences? Do they communicate with one word? Like, try to describe it a little bit for me. Mobility, how do they ambulate? Do they need any assistive devices? Is there a need for physical therapy? Toileting needs, do they need diapers just at night for accidents? Are they completely bowel and bladder incontinent? Do they need assistance with their activities of daily living? And if so, is PCS offered? And if you're requesting or documenting that PCS is already received, make sure you're listing the ADLs that PCS is going to assist with. What therapies do they receive at school, and where community therapy is offered? What assistive devices or durable medical equipment do they have or need? And then any special procedures or medical equipment like G-tube, trach, catheter, and how often is that special procedure administered, and is there a need for skilled nursing or extended home health? And then the psychiatric behavioral section is going to be a narrative description of the person's psychiatric status, diagnoses, and significant behavioral concerns. Address behaviors at both home and at school. So you want to talk to the family and also look at the IEP, see if they have a behavioral plan and with the IEP documents. So describe the behavior, what exactly does it look like? How often do behaviors occur, and try not to use words like frequently or rarely. Try to give me a couple times a month, couple times a week, or daily. Any significant behavioral incidents, and document the month and the year and what exactly occurred. And then if there are any known triggers, being told no, change in routine, which strategies are used, so how are the behaviors managed currently, and then what behavior services were offered and which are requested or received. And then if the beneficiary has an autism diagnosis or has even been labeled, even informally, as having autism, please make sure you're either connecting the class member with ABA or referring them for testing to assess the needs. You can always contact the MCO and request a clinical diagnostic evaluation. And then document if the family declined the service. And if they did decline, please revisit ABA with the family at least annually. And as you know, autism services can be most effective when delivered as early as possible in a child's life. Services usually should begin at ages 2 to 6, and the needed early connection is sorted if support coordinators fail to identify ABA as a possible therapy and arrange it unless declined. And it's still available until they're 21, so don't let families feel like they missed it. You can still get a CD and request it. And then there's an evaluation documentation section where you're going to put dates of formal information documents used in the development of the CPOC. So if you're putting a date there, then that means that you have that paperwork on file. And if you're submitting it as an initial or it's selected for monitoring, then you're required to submit the current formal document listed there. And then current means that the formal information document was less than a year old at the time of the plan of care meeting. We already kind of talked about this, but you have to have a current formal document that's less than a year old at the time of the meeting. And then if they're receiving special ed, extended home health, or PDHC, then you're required to have that current plan on file, and then that works as your current formal document. So don't think you have to get an IEP and something from the doctor. If you have the IEP, that'll work. And then if you don't have those, let me know, and we can kind of see if they're receiving or requesting a service. Maybe we could get a Form 90 or just progress notes from the doctor. And then you also have to have a current SOA from OCBD, or you have to have redetermination as a service need if it's expired or expiring this plan of care year. And then there's also a little checkbox for you to check if it's a permanent SOA, and then if it's not a permanent, you'll enter the expiration date. So any questions about that section of the plan of care?
Are these all documented in the email system? I'm not a support coordinator, but I'm the MCO.
Oh, yeah.
And wanting to help facilitate that.
Yeah. Yep. Okay, and then section 3 is CPOC service needs and supports. And this section of the plan of care is going to identify service needs, including the service strategy and a description, how the need was determined, if the individual requests to receive the identified need, and if it's not requested right now, then you'll document the reason why not, the primary goal, who is providing the support, if the service requires PA tracking, and the amount of service approved. The support coordinator will coordinate all services, Medicaid and non-Medicaid, and ensure that the beneficiary receives the services they need to attain or maintain their personal outcomes. When a service is requested, the support coordinator should provide the individual with the medical information forms, like the Form 90, CMS 485, et cetera, which all those are in Appendix R1, that are required for the specific service. The support coordinator should assist with scheduling the doctor appointment, transportation, et cetera, as needed. If it is not a Medicaid service, the SC is to assist in locating resources to provide the service needs. Identify all services the individual is currently receiving and those services that are requested, both Medicaid and non-Medicaid, clearly identifying each service and the amounts approved. List every service need separately. So you have to do one for school speech therapy, one for community speech therapy. Make sure to select the appropriate service from the service strategy pick list, and then that's especially important for ABA and specialized behavioral health, because those are always going to be PA'd through the MCO. So if you select ABA from the pick list or specialized behavioral health from the pick list, then your tracking log, your tracking required action, the prompts that you receive will always be the Medicaid managed care ones. And then the description box should clarify the service need that is requested. So like for PCS, you can just put PCS. Like we don't want to put providers' names there because then you would have to resolve that service need and open up a new one every time they need to change providers. So just keep it very general. Don't put requesting because that's going to change when they're receiving it. Just, it's basically there if the pick list isn't clear enough. So if you put other, then you would be able to type the description of what the service is. And if you run out of room, can't explain what service it is, there's the additional information box on the next page. Okay, so all the bold ones that you see on this slide are what the pick list is, and then I have a description of what services would fall under that. So PCS for EPSDT PCS. Home health is going to include extended home health, intermittent nursing, or in-home speech, occupational, or physical therapy. Medical equipment and supplies, so you want to capture one-time durable medical equipment that they already have or are requesting, like wheelchairs, hospital beds, weighted blankets, and then ongoing DMEs like formula, trach supplies, or G-tube supplies. And then we have an OT, PT, and ST drop-down box for community therapies. Specialized behavioral health, you can use that for psychiatrists, behavior meds, counseling, CPST, any of the other behavioral services. Dental services, eyeglasses, transportation, diapers, school, to capture IEP services like therapy, assistive technology, social worker, nursing. We have a vocational and an employment drop-down box, transition. And again, if the beneficiary is going to be 20 and a half years old, that plan of care year, ELSIS will prompt you to add that. Pediatric day health care, applied behavioral analysis. We have an other, home modifications, community services, redetermination if the SOA is going to expire that plan of care year or is already expired. OCDD services like family flexible fund, family support, or respite. We have a CSOC drop-down box, and then I encourage y'all to put CSOC, wraparound, because anyone that's in CSOC is going to have a wraparound facilitator, and then also add separate CSOC service needs if they're receiving peer support, parent support, independent living, skill building, or short-term respite. And then we have evaluation if they need a psychological or clinical diagnostic evaluation, EPSDT screening exam, hearing aid, hospice, and then physician professional if they need a referral for a doctor or anyone that they're overdue for a visit with. And you don't have to list like every single doctor that they see, just the ones that they need a referral to or are overdue for. And then, so after you select the service need and enter the description, you're going to select how the need was determined, and then you're going to use the checkbox to identify if the service is requested. So if it's not being requested right now, then you have 3 options to explain why. Carried over resolved is if the service is no longer an identified need. And then the next time that I review that plan of care, if I approve it with the carried over resolved, then it'll fall off of your service needs list and you won't have to keep addressing it at your quarterly visit. So only use that one if it's no longer a need. Like diapers, now they're potty trained, so we're going to take that off, carried over resolved. And then we have family does not want if we know that it's an identified need, but the family is just declining it. So a doctor recommended speech therapy and the family declined it. We know it's an identified need, they still need it. So it's going to stay on there, but then that'll document that, you know, we're not going to be doing any of the PA tracking right now because the family's declining. And then other explain next page is if the service need is on hold. So the parent says, I want this service, but I don't want it right now. So like during COVID, you don't want a PCS worker in your home, but you're going to want it later. Or speech therapy, you only want it during the summer. Keep it on there so that, you know, if the support coordinator changes or whatever, we can still keep talking to the family about it. We know it's coming up, and it'll just have the SC document that they're following up with the family every quarter to see when it's going to be requested. And then always explain your reason in the additional information box. And then there's a drop-down box to select the primary goal. And then the little check boxes are going to indicate if the service is currently received. And then you'll check the appropriate box of who will be providing or funding the service. So there's Medicaid, school, community, family, or OCDB. And you can use family if they're paying for it out of pocket or if the private insurance is covering it. And then requires PA tracked by SC must be checked for all requested Medicaid services that require a prior authorization unless with a valid reason, and how the SC will ensure the service need is received is documented in the additional information section. Indicate the amount approved, and then assure and document at the time of the CPOC meeting the individual understands that services and goals may be added whenever a request is made if they choose not to access a service when the need is first identified. Okay, so to generate a PA tracking log in ALSIS, you have to check Medicaid and requires PA tracked by SC for each individual service need that you need to do the tracking for. And then the only valid reason for not tracking a Medicaid service is if the PA is issued monthly. That doesn't give us enough time to follow the timelines. If the extended home health nurse is the person ordering and tracking the medical supplies, if the beneficiary is on a wait list for the service, but you have to document that you offered alternative providers for whom there may not be a wait list, and document the family's response, confirm the wait list placement with the provider, notify, if it's legacy Medicaid, you're going to notify the LDH PAL, and if it's a Medicaid managed care service, you're going to notify the Medicaid managed care case manager. And then follow up with the provider, not the family, but the provider directly at least quarterly to ensure that they move up the wait list. So you should, if it's a Medicaid service that requires a PA and they're placed on a wait list, you have to open up the tracking log, send your referral to either the provider or Medicaid managed care, complete your 15-day contact with the provider to confirm the waitlist placement, and then you'll notify either the LDH PAL or Medicaid managed care of the waitlist placement, and then you can untrack it. So if you're ever documenting that they're on a wait list, I should be able to look at your tracking log and see that all the steps were taken. And I can send you a little like cheat sheet that walks you through all the steps. And then for community therapies, if you get to a 35 or 60-day PAL, if you can confirm with the family and the provider that the service is being delivered, a PAL referral and continued PA tracking would not be needed. But when you receive a PA, it is to be entered on a tracking log and PA tracking will restart. And all of that's explained in Appendix R4. And then if the MCO does not require a PA for the service, then there's no PA tracking. And if the beneficiary's behavioral health services are being prior authorized by Magellan, while the child is enrolled in CSOC, PA tracking is not required for the behavioral services. So any questions about those? And then this is what the service needs looks like in ALSIS. Okay, and then the next tab is going to be Section 4, Additional Information and CPOC Participants. The beneficiary and the legal guardian must be present if you're conducting a CPOC meeting. And then you're going to have a paper form, and it's your responsibility to have everyone sign the printed ELSIS CPOC signature page, indicating their participation in the meeting. And again, if a person is present at the meeting, they should sign in the planning participants box. The beneficiary and/or legal guardian or authorized representative must sign and date the completed plan of care. The support coordinator conducting the meeting must sign, and then the SC supervisor is going to sign off after they completed their review and prior to submitting the CPOC to SRI. So you're gonna have your paper form from your meeting, and then when you go back to your office and you're working on the plan of care, you'll input all of that information into ELSIS, so it should match the paper form. The signature date of the participant's or guardian signature on the CPOC signature page is to be entered into ELSIS, so not the date that you're putting it into the system, but the date that you held the meeting. And then the support coordinator must sign and date the CPOC and have their supervisor review the plan. And then it'll be ready for supervisor review. So you'll just check that box, and then it'll get submitted to your supervisor in ELSIS. And then right next to the CPOC participants, there's an additional information box, and that's for you to address information regarding service needs and support. So you can list the names of all service providers and any additional strategy information. If they're on a wait list and PA tracking is not checked, confirm that you offered alternative providers that may not have a wait list and the response received. Identify that the wait list placement was confirmed with the provider and that the SC notified the LDH PAL for legacy Medicaid services or the Medicaid Managed Care case manager for MCO services, and also explain how you will ensure they move up the wait list and follow up with the provider at least quarterly. If family is checked instead of Medicaid for services typically covered by Medicaid, explain why. So it's covered by private insurance or the family chose to purchase, et cetera. And if any needs are marked as carried over resolved, family does not want or other, explain next page, document why. And then you'll be prompted to document that you explained and reviewed the Medicaid services chart and Medicaid EPSDT services, which is Appendix F. And it'll also ask if you offered EPSDT screening services and if those are requested. And then you'll identify how often the goals and support strategies will be reviewed. The CPOC must be reviewed by the support coordinator at least quarterly and revised annually and as needed. And this is what that section looks like in ELSIS. And then the next tab is going to be CPOC approval information, where the SC supervisor will sign off on the plan of care, and that denotes that they approve and agree with the content of the CPOC being submitted. The formal information documents listed under evaluation documentation used to develop the CPOC, the prior plan of care, service logs, and quarterly reviews must be reviewed by the supervisor for identified needs and the status of requested services. The entire CPOC must be reviewed to ensure that all identified needs are addressed, all required information is included, information is edited and updated, and no discrepancies exist. And then there's going to be the submit for review by LDH, where the SC supervisor will check that box, and that'll get it submitted to me. And then there's also a See Service Tickets button, and that just lets you easily pull up service logs from that plan of care year, since that's required to be reviewed by the SC supervisor prior to submittal. And then there's also an approval denial information box where I'll put notes either about deficiencies, or I may even have just some approvable notes like enter an interim CPOC and make these little changes. Or if I had to issue a short-term PA because the SOA expired, that'll all be documented in there with what the real CPOC dates are going to be. An approvable initial CPOC must be completed and sent to SRI within 35 calendar days of the date of referral to the support coordination agency. If the approvable CPOC is submitted timely, the PA will begin on the CPOC participant signature date. If the CPOC is late, the PA will begin on the approvable CPOC submit date. And then refer to the aging report and analysis, and that'll have a count of how many days that participant has been linked to the agency. The annual CPOC meeting should not be held more than 90 calendar days prior to the expiration of the current CPOC. The approvable annual CPOC must be completed and submitted to SRI within 35 calendar days of the CPOC expiration date. And if the CPOC is submitted late, you will not meet the flat rate billing requirement of a timely CPOC. And refer to the CPOC update report and analysis that has the first day that you can hold your CPOC meeting and then the last day to submit the approvable plan of care. And then for initial plans, you'll use Appendix X1 as kind of your cover sheet, and then you'll submit all the documents listed there. And if they're labeled as special needs, it'll say it across all the screens in ALSIS. You'll submit Appendix X1 with all annual plans. And then if that plan of care is randomly selected for monitoring when it's submitted for review. So when the SC supervisor actually checks the submit box, a little message box is going to pop up on 10% of them saying that it was selected for monitoring. And then you have, I think, 2 or 3 business days to submit Appendix X2 and the required documents. But for other annuals that are not special needs and are not selected for monitoring, you'll just keep the documents in the case record and then submit them to me if needed. The support coordinator is responsible for requesting and coordinating all services identified in the CPOC immediately upon completion of the plan of care and prior to approval from SRI. Since approval of Medicaid state plan services is through the prior authorization unit, there is no reason for the support coordinator to await SRI approval of the CPOC before making referrals for necessary services. Again, the CPOC does not control the services. This process only controls the payment to support coordination agencies. I think you've got a screenshot of that section. And then the typical weekly schedule, which is a paper form, is a tool that the SC uses to assure that services are delivered at appropriate days and times and do not overlap unless this is medically necessary. You'll include all approved services that they're currently receiving and new services that they're requesting. You'll show when the beneficiary is in school, at home, or participating in other activities. The schedule can be forwarded to in-home providers and prospective providers to support and clarify prior authorization requests. If prior authorization is denied and not appealed, or if for any other reason the plan services are not delivered, the schedule should be amended to reflect services actually put in place. If the beneficiary wishes to change any of the times for established services, the support coordinator shall give the revised schedule to all appropriate providers, informing them of time changes to facilitate the change. And that document will just be kept in the case record. So any questions about CPOCs, how to capture service needs, any of that?
When is that uploaded to the, is that when it's complete and approved by you, or while it's in process?
While it's in process, you should be able to see all of them. So when the SC gets the linkage, they'll open up an initial plan of care, and then anytime that you need to make a change, so for all your quarterly visits, you're going to enter an interim CPOC, and then when it's time for your annual, you'll enter an annual. So you may see a bunch of plans of care in there, so it could be updated as much as needed. If a service is requested, they would have to go in and add that as a service need, or if it's declined. So you may see a bunch of plans of care in there.
And if they have a new support coordinator assigned to them or whatever, when would that be uploaded? How would I just have to read one where I didn't know they had a support coordinator.
Yeah, so I believe the MCOs can see it when the PA is actually issued. So I think they do have to have a support coordination PA for you to see it, and then they also have to have the MCO listed in either the physical MCO agency or behavioral MCO agency box. So if you find out that someone has a support coordinator and you don't see them in ALSIS, you can give me a call and I'll get them to add that so you can access it, which SRI does, I think, get that data once a week, and we put it in there systematically, but if the SD changed it, then I think we don't touch it again. Okay, so now we're going to talk about coordination of services and PA tracking. So once the needed Medicaid service, personal care, medical equipment and supplies, home health, et cetera, has been identified in the CPOC, it is the support coordinator's responsibility to make referrals to the appropriate provider. Again, do not wait for SRI to approve the CPOC. The support coordinator should provide as much assistance as possible to the family to identify and obtain other non-Medicaid services. Hold on just a second. Okay. The CPOC is considered a holistic plan. Therefore, the support coordinator is responsible for coordinating all identified service needs, including paid and unpaid supports, as well as non-Medicaid services. The support coordinator must be knowledgeable of potential community resources, including formal resources such as Supplemental Nutrition Assistance Program, SSI, and housing. Some Medicaid services, such as PCS, home health, and durable medical equipment, require prior authorization before they can be provided. Typically, a Medicaid enrolled provider of the service develops and submits an application for the service to the prior authorization unit. Requests may be denied if the item or service requested is not medically necessary or if it is outside the scope of services covered by Medicaid. A notice of denial will be sent to the beneficiary, the provider, and you, the support coordinator, if you are properly identified in the request. The beneficiary then has the right to appeal the denial. So for beneficiaries and legacy Medicaid for their physical health services, prior authorization requests are acted on by the prior authorization unit of Gainwell Technologies, a company that contracts with LDH to perform this function. For beneficiaries and managed care organizations for their physical health services and or behavioral health services, prior authorization is handled by the individual MCO. The beneficiary's MCO must prior authorize some specialized behavioral health services, including CPST, PSR, ACT, FST, home builders, and MST. And those are all identified on the rehabilitation services slide that we talked about earlier. And then again, if they're in CSOC, those are going to be accessed through Magellan, and you would just indicate that and you wouldn't have to do the PA tracking. And then again, legacy Medicaid is traditional Medicaid for people who are not enrolled in an MCO for most of their health services. And then the Medicaid Managed Care Program is the managed care system for physical health, specialized basic behavioral health, and non-emergency medical transportation services. And there are 5 MCOs working statewide: Aetna, AmeriHealth, Caritas, Healthy Blue, Louisiana Healthcare Connections, and United Healthcare Community Plan. So CHISM class members are part of the voluntary opt-in population for physical health. And again, CHISM under 21, Medicaid eligible on the DD Request for Services Registry. So they may enroll in an MCO for physical health at any time. They may disenroll from an MCO for physical health at any time effective the earliest possible month that the action can be administratively taken. And for more information, you can refer to Medicaid Managed Care Appendix H or contact the Medicaid Managed Care Program hotline at 1-855-229-6848. And then all Medicaid beneficiaries will have an MCO for specialized behavioral health unless they're enrolled in CSOC. And all Medicaid beneficiaries will have an MCO for their transportation services. And again, you can refer to the EMES sheet that I emailed out. But it's very important that when you're checking the Medicaid eligibility at the beginning of every month, that you make sure that the MCO is correctly listed. Like when you pull the client up, it's got the client's name, the support coordinator, and then you're going to see physical MCO agency and behavioral MCO agency. So if that box is blank, then the MCOs don't have access to see that plan of care analysis. And then you could also be getting legacy Medicaid PA tracking prompts when really it's an MCO tracking. And you're going to know it's MCO because it's going to say Medicaid managed care across all your ELSA screens. And then on the tracking log, you're always going to see the teal MCO appeal boxes. So if it's ever incorrect, give me a call and we can walk you through how to correct it. So I think I just settled this. Yeah. Okay, so the support coordinator plays a role in the prior authorization process by assisting beneficiaries in identifying services they will request, providing the specific medical information forms that the physician must complete for the requested service, assisting with the scheduling of physician appointments, transportation, et cetera, to have the forms required for a PA request completed, locate providers willing to submit the request, and assisting if necessary in assembling documentation needed to support the PA request. Make sure providers submit requests timely and track the status of the request. Communicate with the PAL, notifying them of any upcoming doctor's appointment and helping to supply any missing documentation of medical need. Follow through with requests for services until the PA is either approved or denied based on medical necessity, and assist the beneficiary with making a decision about whether to appeal any denials of services and assisting with the appeal if the beneficiary decides to appeal and wants assistance. So first, we're going to talk about locating providers. So again, physical health, either legacy Medicaid or through the MCO if they chose to opt in. So to locate a legacy Medicaid provider for physical health, you can always call the Specialty Care Resource Line to find medical providers of various types and specialties for their beneficiaries and to help identify needed sources for referrals that may otherwise be difficult to find. The Specialty Care Resource Line is supported by an automated resource directory of all Medicaid enrolled providers of medical services, including physicians, dentists, mental health clinics, and many other healthcare professionals. The database is updated regularly. You can also go to medicaid.la.gov, and then you'll kind of scroll down and click on Locate a Provider, and then you'll be able to select the service need you're looking for under provider groups and provider specialties, and then you can either search your region or the specific parish where the beneficiary lives, and then the direct website address for you to bookmark is right there. And then to locate Medicaid managed care providers for physical health services. So the SC should assist with locating a provider that is contracted with their MCO. Resources for locating providers include the online provider directory at myplan.healthy.la.gov. You'll select choose and then go to find a provider, and then you can choose medical health providers and indicate if you're looking to see if a specific provider is contracted with the beneficiary's MCO. And if you select no, then you can just search by provider location and provider specialty. And then PCS can be found by selecting personal care attendant and looking for PCS EPSDT, listed under PCP specialties on the list of providers. You can also call the member services line at each MCO to locate a provider in their network. And those numbers can be found on Medicaid Managed Care Appendix B, or you can access the MCO's individual website to identify contracted providers. Behavioral health is either going to be accessed through the beneficiary's MCO or Magellan if the beneficiary is enrolled in CSOC. So same steps to locate a behavioral health provider. You can go to the myplan.healthy.la.gov, call the member services line, or access the MCO's website. And then I referenced the LA Evidence to Practice website earlier, but you can also go there. They have an interactive map to locate evidence-based program providers near you, or you can contact the beneficiary's MCO and ask for help from a behavioral health care manager to find an in-network evidence-based program provider. And then if it's one of the CSOC kids, you can contact Magellan directly at the 1-800 number, or you can also discuss service needs with the wraparound facilitator. And then the transportation phone numbers are going to be found on Medicaid Managed Care Appendix B. And then dental services, you can contact the beneficiary's dental plan, either DentaQuest or MCNA Dental. Okay, and then we added waitlist placement. So again, if at any time a beneficiary is placed on a waitlist for a needed service, the SC must document that the class member was offered alternative providers for whom there might not be a waiting list and the response received. For legacy Medicaid services, the SC must notify the LDH PAL of waitlist placement, Appendix S. And for Medicaid Managed Care services, the SC must notify the Medicaid Managed Care case manager using Medicaid Managed Care Appendix Q. And there's specific little check boxes that you're going to mark that they're on the wait list. The SC must follow up on waitlist placement with the provider at least quarterly to ensure they move up the wait list. What if you're unable to locate a legacy Medicaid provider? You'll call the contact person listed on the Medicaid Services Chart, Appendix C, if it's for legacy Medicaid, and make sure you contact the correct program subject matter expert when information is needed, i.e. DME staff for DME related services. If the service contact person is unable to assist, call the LDH program staff line and tell them you cannot find a provider. The LDH program staff line's hours of operation are 8 a.m. to 4:30 p.m. with a voicemail message system for overflow and after-hour calls. The support coordinator must fax the referral to LDH PAL form. If a provider cannot be located, LDH must take all reasonable and necessary steps to find a willing and able provider within 10 days of the referral. What if you're unable to locate a Medicaid Managed Care program provider? If you cannot find a provider from the MCO's website or the provider directory, which is willing to submit a prior authorization request, call the MCO's member services line, which operates from 7 a.m. to 7 p.m. Monday through Friday for assistance. The support coordinator must fax the referral to Medicaid Managed Care case management form within 3 days of the date of service request to get assistance from the MCO with locating a provider. If the MCO is unable to locate a willing provider within 10 days of the referral, the SC should submit a referral to the LDH PAL using Medicaid Managed Care Appendix S. LDH will forward the referral to the MCO requesting notification upon resolution. What if a legacy Medicaid provider is unable to find staff? If the provider is unable to find staff after the service has been approved, the support coordinator must notify the LDH prior authorization liaison using the referral to LDH PAL form. The support coordinator must call the LDH program staff line. The support coordinator should assist the family in finding another provider agency with available staff from the LDH website list of providers. If a provider cannot be located, LDH must take all reasonable and necessary steps to find a willing and able provider within 10 days. What if the Medicaid Managed Care provider is unable to find staff? If the provider is unable to find staff after services have been approved, call the MCO's member services line, which operates from 7 a.m. to 7 p.m. for assistance. Support coordinator should fax the referral to Medicaid Managed Care case management form to the MCO to request assistance. If the MCO is unable to resolve the issue within 10 days of the referral, the SC should submit a referral to the LDH PAL Medicaid Managed Care member using Medicaid Managed Care Appendix S. LDH will forward the referral to the MCO requesting notification upon resolution. Okay, so PA tracking begins with the request for the service, not when the choice of provider or prescription is received or when the CPOC is approved. To begin PA tracking, add the service as a service need on the CPOC service needs and supports and ELSIS and check the Medicaid It requires PA tracked by SC boxes for that service strategy. Then follow the prompts on the tracking required action report, beginning with opening an EPSDT PA tracking log. The electronic PA tracking log will be used to document the nature and specific amount of each service being sought, provider and PAL referrals, provider contacts, and the information about approval, denial, and appeals. A separate PA tracking log is completed for each service that requires prior authorization. A new renewal tracking log is used for each PA cycle after the reminder notice for renewals is sent to the provider or Medicaid managed care case manager. The date the reminder notice is sent is the date of referral for a new tracking log. So you have to keep the date of service request the same as the previous tracking log, and then you always want to update the choice of provider date. If you keep the choice of provider date the same, you'll start getting a bunch of negatives right off the bat on your renewals because your referral to provider is due within 3 days of that choice of provider date. So if you're ever getting negatives and you're not sure why, just give me a call and we can look at those dates. And then a new change in service tracking log is used for changes in existing services. So if they are requesting additional hours or changing providers, and again, keep the date of service request the same as the previous log. The PA tracking log is an important tool for support coordinators for several reasons. It will help you assure the beneficiary is receiving the services requested. It serves as a reminder to contact the provider if you have not received a copy of the request for prior authorization form. It will serve as a reminder to make required PAL referrals, allow you to know at a glance when and if services were or were not approved, serve as a reminder of when the notice should be sent to the provider to renew services, allow you to document information about the PA decision notice, and allow you to document that you offered or provided appeal assistance to the beneficiary and provided the appeals brochure. So these are all the different boxes on the PA tracking log, the type of service requested, date of referral, date packet submitted to the fiscal intermediary, which is Gainwell if it's legacy, or the MCO if it's a Medicaid managed care service, the date of decision, the date you received the notice, any referrals to PAL, the amount approved, and then all of the appeal information. Support coordinators should give the individual a choice of providers unless they are already satisfied with a provider. Assist the individual in contacting prospective providers and finding out if they're willing to submit prior authorization requests. Have the individual list the provider they choose and sign the choice of provider form for EPSDT Medicaid providers, Appendix Z. Give the individual the medical information forms that are required for the specific service. Many forms can be found in Appendix R1. Assist with scheduling the doctor appointment, transportation, etc. as needed, and assist the individual or provider in gathering the appropriate documentation needed to support the request. So tracking required actions for legacy, we're going to do legacy Medicaid first. So once the beneficiary has chosen a provider, the support coordinator will complete the referral to provider form and submit it to the provider within 3 calendar days of the date of choice of provider. For initial CPOCs, the referral to provider must be made within 3 calendar days of CPOC completion or within 3 calendar days of the choice of provider if the date of provider selection is later than the plan of care meeting. And then within 15 calendar days of the referral to provider, you'll contact the provider to confirm that they are working on the request and to see if they need any assistance gathering information. And then within 35 calendar days of the referral, contact the provider and ask if the request has been submitted to Medicaid or if there were problems that you could assist with. And it's within 15 days and within 35 days, but really just think of it as your first contact with the provider and your second contact with the provider. Those are going to be documented on your tracking log. And then you're going to continue to do as needed contacts with them until the PA is either approved or denied based on medical necessity. If a notice of decision has not been received 10 calendar days after the date the provider said they submitted the request, follow up with them on the status. If a call from the PAL has been received, and then 45 to 60 calendar days prior to the date the services are scheduled to expire, you should remind the provider to renew the PA request. The provider must submit the renewal request at least 25 calendar days prior to expiration to assure uninterrupted services. And all this information can be found on Appendix T2, which is kind of a flow sheet. And then required prior authorization liaison referrals. If a PA packet has not been submitted to Gainwell within 35 calendar days, complete the referral to LDH PAL form and submit it to the PAL. Also inform the beneficiary about their right to change providers. If a PA decision has not been received within 60 calendar days, complete the referral to PAL and inform the beneficiary about their right to change. And then other reasons to submit a referral to the LDH PAL, which these won't be captured on the tracking log, but you'll always document over a service log that these were done. So if you need to alert the PAL that a renewal approval has not been received and the previous PA expired, to alert the PAL that a provider cannot be located to submit a request for prior authorization, to alert the PAL that the provider has placed the beneficiary on a wait list for the requested PA service, or to alert the PAL that a provider is not providing services at the times the beneficiary requested, or the amount of services as prior authorized, and the problem cannot be resolved with the provider. And this is what the tracking log will look like for legacy Medicaid, so you won't see those teal MCO appeal boxes. And now we're going to talk about tracking required actions for Medicaid managed care. So once the beneficiary has requested a service, the support coordinator must complete the referral to Medicaid managed care case management form and submit it to the Medicaid managed care case manager. Fax numbers can be found on Medicaid managed care Appendix A. Referral to Medicaid managed care case management should be made within 3 calendar days of CPOC completion or within 3 calendar days of the date of service request. A second referral to Medicaid managed care case management should be made within 3 calendar days of the date of choice of provider. But if they request a service and they already know what provider they want, or they're already receiving the service when they're linked to you, or it's a renewal, you're not going to see those second referral boxes at all, which I think we'll talk more about. Yeah, so first referral is to let the MCO know the service is requested and that they're looking for a provider. And then second referral, or just the referral, is going to be to let the MCO know the choice of provider. And then you'll just see the referral to Medicaid managed care case management box for renewals, or if the date of service request and the choice of provider date are the same, then only one referral is needed, and you will not see the second referral teal boxes on your tracking log. Okay, and then required provider Medicaid managed care case management contacts. So if it's an initial PA request and the choice of provider is not known, then you'll send that first referral, and then you'll do a 15-day and a 35-day contact with the MCO to check on the status of the referral and seek assistance with the choice of provider. Once a choice of provider is made, you'll send a second referral to Medicaid managed care case management and complete your 15-day and 35-day contact with either the provider or the MCO to check on the status of the referral and offer assistance if needed. If the PA packet has not been submitted to the MCO within 35 days, seek assistance from the MCO and continue to follow up with the provider and Medicaid managed care case manager until the packet is submitted. And then if it's a renewal, or if the date of service request is the same as the date of choice of provider, then you'll just send that one referral, and then within 15 calendar days, contact the provider or the MCO to check on the status, and then you'll do a 35-day contact as well. If the PA packet has not been submitted to the MCO, seek assistance and continue to follow up with the provider and Medicaid managed care case manager until the packet is submitted. Contact should be made if a notice of decision has not been received 10 calendar days after the date the provider submitted the request to the MCO or a call from the PAL has been received. And then 20 to 60 calendar days prior to the date the services are scheduled to expire, you should remind the Medicaid Managed Care Case Manager to renew the prior authorization request. And then LDH PAL referrals, if after 60 calendar days from the choice of provider date, the support coordinator has not received a decision and the MCO has been unable to resolve the issue, the SC must complete the referral to LDH PAL Medicaid Managed Care member, Medicaid Managed Care Appendix S. And then other Medicaid Managed Care Case Manager referrals are going to be to alert the MCO that you have been unable to locate a willing provider, to alert them that a renewal approval has not been received and the previous PA expired, to alert the MCO that a provider is not providing services at the time the beneficiary requested and or the amount of services prior authorized and the problem cannot be resolved, to alert the MCO that the member was placed on a wait list. And then other LDH PAL referrals for MCO trackings are going to be to alert the LDH. So they're only going to be done after you've sent the referral to Medicaid Managed Care Case Management and they've been unable to resolve any of these issues within 10 days of that referral. So to alert the PAL that you've been unable to locate a willing provider, that a renewal approval has not been received and the previous PA expired, or the provider is not providing services at the time the beneficiary requested or the amount is PA'd. And again, the problem couldn't be resolved with the MCO, then your next step is to alert the LDH PAL. So prior to sending the referral to LDH PAL, Medicaid Managed Care member, the support coordinator should document all contacts and all attempts to contact the MCO PAL and Medicaid Managed Care Case Manager. The SC must attach the completed referrals along with all service logs and emails related to resolving the issue with the MCO PAL. Note, if the PA notice is not received from the provider, the MCO can give you the PA information over the phone, but do not take a verbal PA information from providers directly. And this is what a LSIS PA tracking log from Medicaid Managed Care Services looks like. You're always going to see those bottom rows of MCO appeal boxes, and then you'll see that second referral box if the choice of provider was not known. Okay, and then renewals of prior authorization for legacy Medicaid members. The providers must submit the packet no less than 25 days prior to expiration of the PA for services to continue without interruption. Some services may not require a full prior authorization packet. So for legacy Medicaid, the support coordinator will send a reminder letter using referral to provider Appendix Q, no less than 45 and no more than 60 calendar days prior to the expiration of the PA. And then renewals of prior authorization for Medicaid Managed Care Services. The number of days prior to expiration that the provider must submit the packet for PA services to continue without interruption varies from plan to plan. And you can see Medicaid Managed Care Appendix D, and some services may not require a full PA packet. So for Medicaid Managed Care members, you're going to send a reminder letter to Medicaid Managed Care Case Manager no less than 20 days and no more than 60 calendar days prior to the expiration of the PA. LSIS service logs should be used to provide a narrative of activities related to the request for EPSDT services, including each activity and contact with the provider, the beneficiary, and the PAL. A separate service log should be used to document activity related to a specific prior authorized service. The LSIS service log should be used for documenting all contacts with the beneficiary, provider, MCO, SRI, LDH program staff line, and the PAL. The service log should also be used to document the receipt or the approval, denial, or reduction of services, the monthly contact with the beneficiary family regarding the status of implementation of services, and all support coordination activities. These entries must be up to date as SRI and health standards may request to review this information in order to verify services and prior authorization information. This is what the ELSIS service log looks like. Okay, and now we're going to talk about the prior authorization liaison. The PAL unit was established to facilitate the PA approval process for Medicaid beneficiaries under age 21 who are on the Developmental Disabilities Request for Services Registry. The Chisholm versus LDH lawsuit settlement stipulates that the support coordinator is notified of request, status, and any delays to the PA approval process. The PAL will maintain a tracking system to ensure support coordinators remain aware of the status of PA requests, submission, decision dates, and reconsiderations. PA requests are given to the PAL when the request cannot be approved due to lack of documentation or technical errors like overlapping dates of service or incorrect procedure codes. The PAL will attempt to resolve the problem. Within 24 hours of the PAL receiving the request, the PAL makes the initial contact by phone or fax to the provider, the beneficiary, and the support coordinator. If the issue is not resolved after 10 days of initial contact with the provider, a notice of insufficient documentation is sent to the provider, the beneficiary, and the support coordinator, advising them of the specific documentation needed. The beneficiary has 30 calendar days to either supply the needed documentation or notify the PAL that the appointment date that has been made with the health professional to obtain it. So the support coordinator's role is to communicate promptly with the PAL to facilitate requests for information, communicate with the individual and provider, and provide assistance in assembling documentary support on prior authorization requests, and follow up so that a PA decision is received instead of having the service denied due to a lack of information. And then track the status of requests. Advise the PAL of providers not actively developing requests, inform beneficiaries of their right to choose another provider, and assist beneficiaries in locating another provider. If a notice of insufficient documentation is received, assist the beneficiary in obtaining documentation. If you are not sure enough additional information is available, help the beneficiary schedule an appointment with the health professional and return the second page of the notice filled in with the date of the appointment to the PAL. And then if you ever close a PA tracking log that had a PAL referral sent to LDH, please notify LDH of the closure date and reason. This allows LDH staff to focus on the active PAL referrals. And then we have the contact information for the Gainwell Technologies PAL, if they ever call you. And then your LDH PAL single point of contact is Nancy Spillman. And then you can refer to Medicaid Managed Care Appendix A for a list of all of the MCO prior authorization contacts at each health plan. And then Appendix R has some of the Medicaid prior authorization packets, and R3 has a sample of the PAL notices. So to summarize, if additional information is needed to process the request, the PAL will contact the provider, the beneficiary, and the support coordinator within 24 hours. The SC is to assist in obtaining additional documentation, but this does not supplant the responsibilities of the provider. The support coordinator will receive a copy of all notices, approved, denied, reduction in services, and requests for additional information regarding the requested service. If a beneficiary's service is denied or partially denied, the EPSDT prior authorization tracking log and EPSDT ELSIS service log should document that the beneficiary was informed of appeal rights, they were given the appeals brochure, the SC offered to assist with the appeal. If assistance was given, the coordination of documents, the submission of documents to the appeals office, or if no documentation was available, the date the appeal was filed. If the support coordinator did not assist with the appeal, the reason assistance was not provided, and if an appeal was filed, the response to the appeal and the final decision, and all that's on your tracking log too. And then for Medicaid Managed Care appeals reduction in services, for services authorized by the MCO that are denied or partially denied, the beneficiary, provider, and support coordinator will receive a notice of denial. If services are denied or partially denied, the beneficiary may appeal the decision by following the appeals procedure sent to them, the provider, and the SC by the MCO following the denial or partial denial. The support coordinator must inform the beneficiary of his or her appeal rights, go over the appeals brochure that both parties received from the MCO, and offer to assist the beneficiary with the appeal process fair hearing if the beneficiary decides to request the appeal. If the internal MCO appeal decision is upheld, the beneficiary has the right to appeal to the Department of Administrative Law, and you can refer to Medicaid Managed Care Appendix F and T1. For beneficiaries with legacy Medicaid or for those with the MCO, after the internal MCO appeal process has been exhausted. If services are denied or partially denied for any individual whose claim for medical assistance under the plan is not acted upon with reasonable promptness, or if the member alleges that services are not made available with reasonable promptness, the beneficiary may appeal by mailing or faxing a written request for a fair hearing to the Division of Administrative Law, Health and Hospital section. You can call, or you can also fill out the form at that website. And the support coordinator must inform the beneficiary of his or her appeal rights and provide the appeals brochure. Review the brochure in its entirety, and information on appeals can be located on the internet at ldh.louisiana.gov. Explain that the beneficiary can receive the services or items that have been approved and appeal for whatever was denied. They do not need to choose between filing an appeal and receiving the approved services. Explain that services can be continued pending appeal if the appeal is filed within 10 days of the notice of denial. The support coordinator must ask the individual if they need or want assistance with filing the appeal, and the SC must assist with an appeal if assistance is wanted by the beneficiary. And then regardless of whether or not they want you to help, you'll follow up with the beneficiary within 20 calendar days of the appeal request to see if they have received a response or need additional assistance. The support coordinator should follow up again with the beneficiary at least 90 calendar days after the appeal was sent to check on the final decision regarding the appeal. And you can review the appeals section of the handbook, pages 97 to 102. Okay, and then, so any PA tracking questions? Okay. And then follow-up requirements. So the SC must make contact with the beneficiary as needed until each service included on the CPOC is fully implemented, including receipt of all prior authorized services. Contacts may be required to assure implementation of requested services, determine a service start date after the PA is received, assist is requested with identified needs and problems with providers, follow up on obtaining information to complete a PA request, or offer to assist or to offer assistance with an appeal. The support coordinator must make contact with the beneficiary at least monthly to assure implementation of the services requested on the CPOC. If the beneficiary is not satisfied with their provider, the support coordinator should follow up with the provider. If the issue cannot be resolved, alert the LDH PAL for legacy Medicaid services or alert the MCO for Medicaid Managed Care Services. And if the MCO cannot resolve the issue within 10 days of the referral, alert the LDH PAL using referral to LDH PAL Medicaid Managed Care member. And then your quarterly visit, the SC must complete a face-to-face visit with the beneficiary and parent or legal guardian each quarter in order to identify service needs and status through review of the CPOC. The service needs section of the quarterly review should document if services are received and if the beneficiary's family is satisfied with the services and their providers. Any additional services requested, any scheduling issues, and then you'll complete the EPSDT CPOC quarterly review checklist and the progress summary located in OutSys. And the face-to-face quarterly visit for EPSDT does not have to be completed in the beneficiary's home. However, the CPOC meetings, both initial and annual, must be held at their home, and their original signature page must be kept in the case record. If any complaints against support coordinators or legacy Medicaid providers are detected as a result of the quarterly review, the beneficiary should be given the participant complaint form to complete and return to health standards. If the support coordinator detects that the beneficiary has any data dissatisfaction with a service provider, it's the SC's responsibility to assist the beneficiary in resolving any problem and let the beneficiary know of his or her right to change providers. If the beneficiary has a complaint against their MCO, they should be given the Medicaid Managed Care Complaint Form, which includes the Medicaid Managed Care Program Assistance Line, and you can also email healthy@la.gov for filing complaints against a Medicaid Managed Care Program provider or the MCO. And then this is a screenshot of what the ELSIS CPOC quarterly review looks like. So each time that you do a quarterly, you should be documenting it via a service log and then also entering an interim CPOC or an initial or an annual and completing this CPOC quarterly review tab. Changes to the CPOC, including the typical weekly schedule, should be made to reflect changes if prior approval of a requested service is denied and not successfully challenged through a fair hearing request or other advocacy, when strategies are needed to deal with problems with services or providers, resolving problems and overcoming barriers to beneficiaries receiving services is a key goal of the CPOC process, or when significant new information is obtained from a medical appointment or assessment, including psychological and behavioral services assessment. The CPOC should be updated and goals and objectives should be added and or revised according to the most recent information available. So again, you can pull forward as many interim CPOCs as you need to keep the information current. The EPSDT quarterly report will be completed using information entered into ELSIS. Each agency must have all of the required information entered at the end of each quarter so that the report can be generated. It's the responsibility of the agency to identify beneficiaries with a prior authorization not issued within 60 calendar days of the beneficiary's request. As part of that identification, the agency must review all documentation. So if someone shows up on the report as a PA not issued within 60 days, you're going to review the CPOC, the PA tracking logs, service logs, et cetera, prior to the end of each quarter. So the quarterly report is always due to SRI by the 5th day of the month following the end of the quarter. So it's always April 5th, July 5th, October 5th, and January 5th. And it can be turned in early. If it's turned in, like around Christmas or whatever, we can always run it again and make sure none of the numbers changed after the quarter. The SCA must use the quarterly report checklist, which is Appendix W1, and the report must include a printout of the quarterly report from ELSIS reviewed and signed, a quarterly report of CPOC revisions, so you're going to use Appendix W2, and then you're going to attach a printout of the service needs changes report. So the service needs changes is just that, like if the SC ever made a change to the service need, that quarter will show up on there. And then on Appendix W2, or W2, if you had any other significant changes to the plan of care, you can handwrite those onto that appendix. And then record reviews, Appendix W3 for PAs not issued within 60 days or any gaps in prior authorization periods. And then an explanation of beneficiaries without a choice of provider. So you can put in an email, you can attach a Word document, but just there's going to be a list of trackings without a choice of provider. And then some people will send me the most recent service log, which is something to show if there's any barriers and what the strategy is to remove that barrier, or if it's just that the family's still making a choice. And then documentation of EPSDT training for any new hires. The report will include the name of the beneficiaries and the services for the following: any PAs not issued within 60 calendar days, beneficiaries with service gaps in the authorization period, and beneficiaries who submitted requests for appeals within the quarter. The record review for the quarterly report is to be completed for each beneficiary and each service listed on the quarterly report as not having a PA issued within 60 days or a gap in authorization period. If no gap is found or the gap was due to the family's choice, fill out page 1 of the record review to document this, and then you can remove it from the quarterly report, like just take the printout that you're going to send to me that you sign off on and change the number by 1. So if someone shows up as a gap and they don't really have a gap, like sometimes ELSIS puts people on there that don't belong, you'll just reduce that number. And then I've also had people where it'll show up as, what section is that under? It's like participants with service needs that need to be tracked. Sometimes it'll pop them on there if it's at the can start the renewal and not the must start. So if that ever shows up on there, just make a note of that and we'll take them off and make those numbers match. And then the EPSDT specialist, if they are not the support coordinator over the case, is to complete the record review. If the support coordinator involved in these cases is the EPSDT specialist, then the on-site program manager and/or supervisor are to complete the record review. Either the number of trackings without a choice of provider must be 0, or documentation and explanation must be attached for each beneficiary and service without a choice of provider. SRI and the LDH attorney will review the information to assure that the beneficiaries are receiving the services they need and the assistance they need to access the services. SRI will request supporting documentation and information from the support coordination agencies as needed. And then training, so new support coordinators and trainees must receive EPSDT training during orientation and prior to being assigned an EPSDT caseload. All support coordinators and trainees must complete EPSDT training each year as part of their 20 hours of annual training. The agency's designated trainer and supervisors will be responsible for training the staff. And then all trainers and supervisors must receive EPSDT training during orientation and prior to beginning supervision of EPSDT support coordinators. And all designated trainers and supervisors must complete EPSDT training each year as part of their 20 hours of annual training. And that training may be provided by SRI or by a trained supervisor or designated trainer within the agency. And then you'll submit documentation of annual training. I'll send out that form after this. And then you'll submit documentation of any new hires with the quarterly report. The on-site program manager is responsible for assuring compliance with all program requirements, and the EPSDT specialist is to monitor that all EPSDT requirements are being met. They shall both check the ELSIS reports at least semi-weekly, and all deficiencies are to be addressed and resolved. And please refer to handbook pages 121 to 125 that goes over the most important ELSIS reports. And you can also give me a call with any questions about how to read those. And then reminders, the purpose of support coordination is to coordinate all services and to ensure the beneficiary receives the services that he or she needs. If at any time a provider is not actively working on behalf of the beneficiary, contact the PAL and contact SRI if you have questions or your state office regarding policy. Okay, so we're almost done. So part 2 is going to be Medicaid managed care program, and then part 3 will be COVID exceptions. So the purpose of this section is to provide an overview of Medicaid managed care program for SC agencies, designated trainers and supervisors to use in conjunction with the training handbook and the Medicaid managed care appendices. So again, Medicaid managed care program is the managed care system for physical health and specialized behavioral health. And most Healthy Louisiana members will receive all of their Medicaid covered services through their health plan. CHISM class members may choose to have all of their health care through the health plan or only their specialized behavioral health services. This is called opt-in. So that means that they may enroll in an MCO for physical health at any time, and they may disenroll from an MCO and go back to regular Medicaid at any time effective the earliest possible month that the action can be administratively taken. Some Medicaid beneficiaries only receive specialized behavioral health and transportation through their health plan. CSOC beneficiaries will receive coverage for all covered services except their specialized behavioral health and CSOC services, which will be received from the CSOC contractor, Magellan Health Services of Louisiana. So any changes to the health plan, the effective date is always going to be on the first day of the month. Any transfer request processed on or before the second to last business day of the month will be effective the following month. Any transfer request processed on the last business day of the month will be effective on the second following month from the date of request. And we're going to give you examples of all this too. So Chisholm class members who have previously disenrolled from an MCO may re-enroll in an MCO only during the annual open enrollment period, effective the earliest month that the action can be administratively taken. Chisholm class members do not need a reason to change health or dental plans between November 8th, 2022 and March 31st of 2023. Chisholm class members have a 90-day disenrollment period from the effective date of the enrollment during which they change MCOs for any reason. After 90 days, Chisholm class members will be locked into the MCO until the next annual open enrollment period unless they opt out of the Medicaid managed care program or show cause for disenrollment from the MCO. And there are examples. So if a Chisholm class member calls the Healthy Louisiana line to enroll on April 8th, the effective date for enrollment will be May 1st. If they call Healthy Louisiana to disenroll on May 8th, the effective date of enrollment back into Legacy Medicaid will be May 1st. And then if they call on the second to last business day, so if they call on April 30th to enroll, the effective date will not be until June 1st. And if they call on April 29th, their effective date will be May 1st. For more information on opting in and disenrolling from the Medicaid Managed Care Program for physical health services, you can refer to Medicaid Managed Care Appendix H or contact Healthy Louisiana at 855-229-6848. So the 5 ways for Chisholm class members to change their health plan are to log in to their account at myplan.healthy.la.gov. There's also a Healthy Louisiana mobile app that's available for free. They can call the 855 number, and they can also send their enrollment form by fax or mail. And then some of the services excluded from Medicaid managed care are dental services, ICFDD, nursing, IEP, waiver services, targeted case management, early steps, and then LTPCS. MCO members may obtain excluded services under the Louisiana State Plan. However, Gainwell will pay for these services, not the MCO. The MCOs are responsible for informing members how to access excluded services and assisting in the coordination of these. The support coordinator should reach out to the Medicaid Managed Care Case Management for assistance with obtaining excluded services. MCOs offer value-added benefits to their members, which are currently non-covered services by the Louisiana Medicaid State Plan. A complete listing of each MCO's value-added benefits can be found on the MCO comparison chart, Medicaid Managed Care Appendix G. And some examples are rewards for completing health needs assessments, flu shots, et cetera, GED test preparation, life skill and workforce training, cell phone and service, and gym memberships and weight management programs. And then what is the SC's role in Medicaid managed care? Support coordinators should assist Chisholm class members with selecting an MCO by providing information on all 5 plans using the MCO comparison chart. Support coordinators should assure that Chisholm class members' providers are in network. Each plan has primary care physicians and specialists in their provider network. You can search for providers by plan at myplan.healthy.la.gov. Support coordinators should ensure that the medications that the beneficiary is currently prescribed are covered by the MCO's formulary. A common preferred drug list can be found at that website, and it's important to check any medications not listed on the common preferred drug list with each of the plans to see if it's covered. Each plan covers different drugs and has different prior authorization and step therapy procedures. And you can refer to Handbook page 8 for direct links to each of the MCO's pharmacy benefits pages. So before selecting a health plan, Chisholm class members should ask these questions. Is your primary care physician in the health plan's provider network? Are specialists you see in the health plan's providers network? Are specialists in behavioral health providers you see in the health plan's network? What special services does the health plan offer? And then use the Medicaid Managed Care Appendix G health plan comparison chart. Chisholm class members can call Healthy Louisiana to enroll or go online at myplan.healthy.la.gov. Support coordinators are responsible for informing the Chisholm class member of the MCO's contractual obligation to ensure transition of care when enrolling in or switching MCOs. MCOs do not require service authorization for the continuation of medically necessary covered services of a new member transitioning into the MCO, regardless of whether such services are provided by an in-network or out-of-network provider. However, the MCO may require prior authorization of services beyond 30 calendar days. The MCO will honor any active prior authorization up to 30 days or until the transition of care is complete, whether or not the authorization is with an in-network or out-of-network provider. And then after enrolling in the Medicaid Managed Care program, within 10 days, the member will receive an MCO welcome packet, including their member handbook and or a welcome letter. The MCO will also send the member ID card. Within 14 days of sending the welcome packet, the MCO will call new members. Support coordinators should familiarize themselves with the member handbooks for each MCO at these website links. And then we've got a slide with the member services number, which is also on Medicaid Managed Care Appendix B. And you can utilize Medicaid Managed Care Appendix A, and B to contact the MCO to determine how the Chisholm class member can access specific services. This process may vary for each MCO. Support coordinators are responsible for assisting Chisholm class members with obtaining the documentation, including prescriptions, for requesting prior authorization of medically necessary services. Support coordinators should also coordinate assistance with Medicaid Managed Care Case Management, the MCO Prior Authorization Liaison, and the LDH PAL via phone, email, fax, or referral form. Then we already talked about how to locate providers, which is a refresher. There's the online provider directory. You can call the member services line, and you can access the MCO's website directly. And if a provider is not available, you can if you can't find a provider from the MCO's website or the provider directory, which is willing to submit a prior authorization request, call the MCO's member services line. Fax the referral to Medicaid Managed Care Case Management form within 3 days of the date of service request to get assistance from the MCO with locating a provider. If the MCO is unable to locate a willing provider within 10 days of the referral, the SC should submit a referral to the LDH PAL. LDH will forward the referral to the MCO requesting notification upon resolution. SCs are responsible for assisting Chisholm class member with switching providers. Support coordinators should send a referral to Medicaid Managed Care Case Management form to inform the MCO of the member's desire to change providers. Members have the right to change providers at any time. However, approved authorizations are not transferred between agencies. If a member elects to change providers within an authorization period, the current agency must notify the MCO of the member's discharge, and the new agency must obtain their own authorization through the usual authorization process. If a member is being involuntarily discharged, they should receive a written notice and appeal rights from the provider. SC should contact the MCO PAL if the provider fails to provide a discharge notice. SC should maintain communication with the Medicaid Managed Care Case Management through submission of the PA and the final determination. If the service authorization is denied, the support coordinator should assist the Chisholm class member with obtaining the required documentation and ensuring that the documents are submitted to the MCO. Support coordinators should assist the Chisholm class member throughout the appeal process if they choose to appeal. And then all the reasons to submit a referral to Medicaid Managed Care Case Management are listed there and on Medicaid Managed Care Appendix Q. And then we already discussed the reasons for LDH referrals for Medicaid managed care case management. If you don't receive a PA within 60 days from the choice of provider date, or if the MCO is unable to resolve any of the below issues within 10 days of a referral to Medicaid managed care case manager. Okay, and then we have some upcoming Medicaid managed care organization changes. Effective January 1st of 2023, Medicaid will have contracts with 6 MCOs, also known as Healthy Louisiana Health Plans. So we'll have Aetna, AmeriHealth, Healthy Blue, Humana Healthy Horizons, which is our new one, Louisiana Healthcare Connections, and United Healthcare. Updated training materials with contact information will be sent out to SCAs and published on the EPSDT website prior to January. And then if you ever have questions about the Medicaid Managed Care Program PAL procedures, you can filter those through me. And again, my email address is ksalling@statres.com, and my phone number is 225-767-0501. And any issues with Medicaid Managed Care Program communication processes should be filtered through me, and I'll share them with LDH. Okay, and then we still have our COVID-19 exceptions in place, so we're going to go over those real quick. Support coordinators are still allowed to utilize telehealth or telephone contact and place a face-to-face initial home visit, quarterly reassessments, and in-home annual assessment. But if you're doing this, the beneficiary and the legal guardian must be present to conduct an initial or annual CPOC or a quarterly visit. Telehealth is the preferred contact method. However, if the beneficiary does not have access to Skype, FaceTime, etc., telephone contact is acceptable. If the SC needs to use this exception, the SC must document the reason it's being used on the service log, and face-to-face visits can still be conducted. Current supporting formal information assessments may remain in place through the duration of the COVID-19 event. So formal information like IEPs, Form 90s, home health plans of care, those kinds of things. If the support coordinator needs to use this exception, the SC must document in the CPOC the barriers to obtain the current formal information document, strategies to obtain, and attempts made. CPOCs are allowed to be completed without the signatures during the duration of the COVID-19 event, but everyone present, it should still be documented in your service log who was on the phone call or on the telehealth visit. If it's a plan of care meeting, you should still be documenting in the planning participants who all was on the phone call or telehealth. Agencies must continue prior authorization tracking, but if a service need needs to be put on hold due to COVID, you can enter an interim CPOC, mark the service need as on hold, and document in the additional information section that the service is on hold due to the COVID-19 event. Okay, and then I've got these 2 handouts. If you didn't get a copy, it was attached to the first email that I sent with the training materials, and if you're in person, there's some copies at the back. So the first one we're gonna go over is Informational Bulletin 20-9. And the most recent one was revised 9/22/21. So LDH is temporarily changing qualifications for providers of EPSDT personal care services during the COVID-19 health emergency. The following guidelines apply. The beneficiary's legally responsible relative or caregiver may be a temporary direct service worker in the absence of agency DSW care. So the only way that you can get approval for this is if there is a staff shortage, and then it's only the legally responsible relative, which is defined as the legal guardian, curator, tutor, or other legal custodian by law or custody order, like power of attorney. Beneficiaries and DSWs may live in the same house, and fee for service or MCO approval for these services will be required Requests will be reviewed on a case-by-case basis, and the provider must have approval from LDH or the MCO. And then on the back of it, you've got the direct email addresses. So if a provider ever has questions about this, you can always, or families, refer them to Informational Bulletin 20-9. If you type that into Google, like LDH, Informational Bulletin 20-9, it'll pop right up. And then this is just an FYI, probably doesn't really apply to us, but we wanted y'all to know about it if a family's asking about it. It's the Act 421 Children's Medicaid Option, or TRFA. And it's, so if you've never had Medicaid and you go to submit a Medicaid application, they'll automatically look at this as an option to see if you're eligible. And then if anybody has questions about it, you can call, or you can email 421-CMO@la.gov. And then I send this as an attachment, so you can like click on the links for it. But basically it's the Tax Equity and Fiscal Responsibility Act. And they don't have, even if their parents earn too much money to qualify for Medicaid, they may still be able to qualify. And then questions and answers. So if there's any questions now or the ones that I previously answered, I'll send those out with the PowerPoint, so you'll have access to the slides. And then I've got my contact information on there. No, if you're in person, you can't see it. So, and then you can also put questions into the chat.
Oh, no, she's a tough standard.
I'll put that out there.
Yeah, we'll get her about that.
Any questions?
No question.
Yeah.
Anybody else, any other questions?
MCO, agencies we added in January, gonna automatically go on our LC.
Yeah, so she had a question about the 6 MCO agencies. So when Humana comes on in January, ELSIS automatically populates the physical and behavioral MCO agency fields in ELSIS if you have an active support coordination PA. So if that changes, it'll show up in there. And then I think the only caveat to that is if the SC goes in and changes it, then I think y'all maintain it for the rest of the time and ELSIS won't take away what you put in there. But again, you'll do your Medicaid eligibility verification check at the beginning of the month and you'll be able to update it if it changed.
Any other questions? All good? Did everybody sign in the sign-in sheet? Validation, getting validation, we're done. And that's it. Thank y'all.